because of the nature of the DNS position, the DNS position allows for a composite or composite of chains to work together so that we can accomplish tasks. And the body has a lot of compensatory strategies it can use. That is why in DNS we're looking for the escape. The person escapes from the position, but sometimes it is difficult in a position that involves multiple chains compensating in multiple ways to identify what is not working. And therefore, you will have to have additional testing to try to bone out what is and they might be DNS positions, but you have to really start looking at, because a 6-month legs up position is not going to tell you about a weak glute. It just is not loading in. Yeah. So now a half high kneeling to stand will tell you about a weak glute, but it might be very hard to see it in bare. Yes. So this is what I mean, that once you have, once you've moved past the chain, you now have to look both at the DNS positions, and you also have to look at positions that isolate functionally the muscle to show me, is this muscle able to be loaded, and especially loaded in the way the patient needs it loaded to stop failing his ADL. Because yes, it might be strong enough to lift their legs up in the air. Their abs might be strong enough to lift their legs up in the air, but it is not strong enough to hold the arabesque or the crunch during the turn or whatever, or to hit the puck without overloading the shoulder. Yeah, that's right. So we need to have a battery. You will need to have a thought process that goes, have I fulfilled these conditions under the time I'm doing the rehabilitation? And then from there, you develop a battery of tests and positions that make sense to you, that are easy to analyze for the most part, and that can help you move the patient into ADL function with a purpose, so that you can choose appropriate exercises and just give them any 3 best exercises that come to your mind. But give them exercises that are based on your findings so that they can not only do the exercises, but you can come back and show them the results and changes that have been accomplished by those exercises. So that is really something that has been on my mind, because you start to realize that, yes, the patient can match your pressure, but he can't lift that 20-pound weight.
Yeah. And that's, I think part of it too, I think you and I always kind of place ourselves in a category, my favorite word, category, of kind of primary rehab, where we don't, a lot of the times, get to the repetitive loading strength training aspect, even though that ought to be part of that obviously needs to be part of the rehabilitation process. Frankly, too, so, I think sometimes the patients are feeling generally better by that point, to where they, sometimes they just kind of fall off, or they don't feel the need to come in much more because they're feeling generally good. Their wrist is better, their shoulders feeling better, their back's feeling better. Yeah, maybe it's a little achy and sore sometimes, but the stretches, Dr. Bill showed me, are helpful with that. I'm just going to go back to the gym and work out and get stronger. And, I don't see them for 6 months or a year. It's only the really dedicated ones, or the ones who are maybe still having a significant
Mm-hmm.
symptom, that
Mm-hmm.
get to that strength, the true, I would say, responsible
Mm-hmm.
strength training, once you've kind of
Mm-hmm.
cleared everything and
Mm-hmm.
checked for
Mm-hmm.
everything.
Yeah. Because even if you're primary, there are times when the patient, is maybe with a trainer,
Mm-hmm.
and the trainer, between your primary intervention and his secondary intervention, there's a gap, and that gap is going to make your patient fail. Because
Oh yeah,
what
definitely.
the trainer thinks is an appropriate load is too much for where the patient is at. And what you are giving and they are succeeding at is too low for them
Mm-hmm.
to make that leap to where
Mm-hmm.
the trainer is. And therefore, sometimes you have to intervene and realize that either the trainer has to peel back to where you are, or you have to step up and meet the trainer halfway by having in your toolbox exercises that will bridge this gap and can be assessed both by you or by the trainer as part of the continuum of the rehabilitation process. So that is also another reason why I think that exercises that are close to the ADLs are very important so that the patient can institute these exercises and monitor them on a daily basis along with what he does so that he can help you move him forward rather than only when he sees you, he gets to um,
Right.
experience some kind of teachable, um, coachable session.
Mm-hmm.
Yeah. Yeah. So that is that. So it makes it very exciting, I think, because the possibilities of using positions and observing the rules of fixed and mobile points, support and phasic function, um, uh, now become really tools that can be transferred to more complex or more upright functions, more well known general exercises that make sense to the patient and make sense to the trainer and have a mainstream purpose. Yeah. So
Yeah.
that is really it.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.